Are you gearing up for radiology board exams? The Radiology Review wants to save you money. Visit our discount code section for current offers on Radiology Review recommended educational resources. Head to theradiologyreview.com and navigate to the discount code section. Terms and conditions apply. Limited time offer. Discounts may vary. Welcome to the Radiology Review podcast with your host, Dr. Matt Covington, a board-certified radiologist. For additional content, please follow the Radiology Review on social media, such as X or Instagram, at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website, theradiologyreview.com.
I'm Dr. Matt Covington, and I want to welcome you back to the Radiology Review podcast. This is part 2 of my episodes on pediatric renal and adrenal masses. Go ahead and check out part 1 if you haven't heard that yet. Once this episode is released, I will make a free downloadable study guide available on my website, theradiologyreview.com. While you're there, also check out the discount code sections on my website, where I frequently have discounts on things like radiology board review resources. Without further ado, let's get into the questions and answers for this episode. First question: a multilocular cystic mass arising from the kidney of a young male child showing a claw or beak sign with classic anechoic cyst fluid and possible septal enhancement with no nodular or solid internal enhancement makes one think of which classic pediatric renal entity? The answer I am looking for is a pediatric cystic nephroma. The classic imaging appearance is that of a multilocular cystic mass arising from the kidney of a young male child with a claw or beak sign with internal anechoic cystic fluid and possible septal enhancement, but without nodular or solid internal enhancement. Note that if solid nodular enhancing components are seen, this would then be most suspicious for a cystic Wilms tumor. So it is really that absence of solid nodular enhancing components that allows you to favor a pediatric cystic nephroma rather than a cystic Wilms tumor on a board exam. Next question: at what age does renal cyst formation occur in multicystic dysplastic kidney? This is slightly a trick question because the cysts in multicystic dysplastic kidney occur in utero. This diagnosis is usually made antenatally or in the first few months of life on ultrasound if performed. In some cases, it may go undetected with risk of renal agenesis during childhood. There is loss of renal function in the areas of renal involvement with multicystic dysplastic kidney. Therefore, bilateral extensive renal involvement is fatal. Next question: what are classic imaging findings of multicystic dysplastic kidney? On ultrasound, a classic imaging appearance would be that of echogenic kidneys with multiple internal clustered non-communicating cysts of varying shapes and sizes. These are typically T2 bright on MRI. With multicystic dysplastic kidney on a MAG-3 nuclear medicine scan, expect poor or absent uptake in areas of multicystic dysplastic kidney, and if extensive involvement, there would be no renal excretion of radiotracer present. Obstructive uropathy may be seen with multicystic dysplastic kidney. Next question: true or false? There is up to a 50% rate of contralateral renal tract anomalies in cases of multicystic dysplastic kidney. The answer is true. This can include contralateral vesicoureteral reflux, ureterocele, renal agenesis or hypoplasia, and or renal tract obstruction. It is important to remember that there is a very common rate of contralateral renal tract anomalies in cases of multicystic dysplastic kidney. Next, what are imaging findings of autosomal recessive polycystic kidney disease? Keeping track of differences between autosomal recessive and autosomal dominant polycystic kidney disease is important for board exams. With autosomal recessive polycystic kidney disease, ultrasound classically shows enlarged and echogenic kidneys that contain multiple, typically small cysts. Look also for coexisting liver abnormalities, including a coarse hepatic echo texture and biliary cystic changes. When advanced, changes of portal hypertension may be evident, including hepatic fibrosis, splenomegaly, and venous collaterals. Note that early in disease on antenatal ultrasound, the cysts may be too small to perceive. Next question. True or false? Autosomal recessive polycystic kidney disease is more common than autosomal dominant polycystic kidney disease. The answer is false. Autosomal dominant polycystic kidney disease is more common. Next question. What is the classic age of presentation for autosomal recessive polycystic kidney disease? This is a bit of a trick question. The age of presentation can vary, and the disease actually manifests differently depending on whether disease onsets earlier or later in the pediatric period. In general, those cases seen earlier in life in the neonatal period have renal predominant involvement, and those that present later tend to have liver predominant disease. The perinatal presentation with renal predominant disease is, however, the most common. Unfortunately, most of these perinatal disease states are not survivable, and most will not survive even 24 hours past delivery. Next question. What are some classic causes of pediatric obstructive cystic renal dysplasia? Pediatric obstructive cystic renal dysplasia can be caused by things such as urethral or bladder outlet obstruction, which can, over time, cause cystic dysplasia of the kidney. Classic cases of obstruction to remember for board exams include posterior urethral valves, a duplicated collecting system with obstruction from a ureterosil, remember the Weigert-Meyer rule, and urethral agenesis. This leads us to two classic, often tested concepts for board exams that are worth reviewing now. First, as I said, the Weigert-Meyer rule, which states that the upper pole moiety is ectopic and prone to obstruction, and the lower pole moiety is prone to reflux. Second, remember that about half of cases of obstructive renal tract pathology in the pediatric population have a vacteral association, that is VACTERL, and I'm pretty confident I've reviewed this on prior episodes, but let's go through it again. V from vacteral is vertebral anomalies, A for anorectal anomalies, C for cardiac anomalies, TE for tracheoesophageal fistula, R for renal anomalies, and L for limb anomalies. Next, what is the classic triad of Meckel-Gruber syndrome? That is Meckel-Gruber, Meckel-Gruber syndrome. The classic triad of Meckel-Gruber syndrome is, first, multiple renal cysts, also termed renal cystic dysplasia, and that is mandatory for this diagnosis. Second, an occipital encephalocyl or holoprosencephaly, and third, polydactyly. Next question. What pediatric renal anomaly is classic with tuberous sclerosis? Tuberous sclerosis is one of those entities that I consider particularly high yield for radiology board exams because it has so many classic imaging findings of various organs. And what you should remember as the classic pediatric renal anomaly with tuberous sclerosis is a renal angiomyolipoma, or multiple renal angiomyolipomas, which are classic with tuberous sclerosis. These will be seen in up to 75% of tuberous sclerosis cases and typically will be bilateral and large. These can grow to a large size, raising risk for hemorrhage, for which surgical resection may be performed as a preventative measure. Coexisting renal cysts may be present. Other common imaging findings with tuberous sclerosis include cardiac rhabdomyomas, as well as cortical and subependymal tumors, as well as disease involvement with various other manifestations which are beyond the scope of the current discussion. Next question. What are some classic features of Zellweger syndrome? And that is Zellweger. Zellweger syndrome is a multi-system disease process, which is also sometimes termed cerebrohepatorenal syndrome. Zellweger syndrome typically presents in the neonatal period and is caused by peroxisomal metabolism derangements. Renal manifestations include hyperechoic kidneys, hepatomegaly may be present, CNS findings include periventricular pseudocysts, as well as polymicrogyria and pachygyria. Next, what are potential renal manifestations of sickle cell disease? With sickle cell disease, renal enlargement is often present with bilateral echogenic pyramids on ultrasound. As disease progresses, the kidneys that were once large may ultimately become small, with loss of normal function, leading ultimately in some cases to renal failure. Renal papillary necrosis and vascular thrombosis, such as renal vein thrombosis, may also be present. Next question. True or false? If a renal cell carcinoma occurs in a pediatric patient, a genetic component is more likely to be present. The answer here is true. Certain genetic anomalies and syndromes increase the prevalence of renal cell carcinomas diagnosed in the pediatric population. For example, a translocation of XP11.2 is associated with development of pediatric renal cell carcinomas. It is important still to remember that renal cell carcinoma is predominantly an adult renal disease. Next, what are classic causes of renal pseudotumor in the pediatric population? A pseudotumor is really any mass or mass-like process which can mimic the appearance of an actual tumor on imaging. Causes of potential renal pseudotumors in the pediatric population include a renal abscess, renal infarct, persistent fetal lobulation, a so-called dromedary hump, that is DROMEDARY, or a prominent column of Bertin, which is BERTIN, but I've typically heard it pronounced Bertin, so I'm going with that. All of these are potential causes of a renal pseudotumor, meaning an imaging finding that looks tumor-like but is not. Next question. What are key imaging findings to help distinguish a column of Bertin from a true renal mass? A column of Bertin is normal renal cortical tissue that separates the normal renal pyramids and is present in about half of individuals overall. However, when this becomes prominent enough, it can appear like a mass on imaging. A column of Bertin is in continuity with the normal renal parenchyma, typically located in the mid-kidney. The tissue in the column of Bertin should have identical imaging appearance to the renal cortex, such as identical echogenicity on ultrasound. CT and MRI also show that the hypertrophied or prominent column of Bertin has identical imaging features, including an identical degree of enhancement to the renal cortex. The renal outline or contour will be preserved with a column of Bertin and is typically distorted with a malignant mass. Next question. What is a persistent fetal lobulation? I told you earlier that a persistent fetal lobulation is one potential cause of a renal pseudotumor in the pediatric population. Let's talk more about what a persistent fetal lobulation is. The kidney forms embryologically as several distinct lobules that ultimately fuse as they grow into what becomes the single kidney. A persistent fetal lobulation results from incomplete fusion of renal lobules that leaves a lobulated or mass-like contour that can almost look like a partially exophytic renal mass. If there are multiple persistent lobulations, an abnormal multilobulated contour of the kidney is seen. Next question. What is the classic ultrasound appearance of pyelonephritis with a renal abscess? On ultrasound, pyelonephritis may appear as abnormal renal hypoechogenicity, that is HYPO, hypoechogenicity, with possible perinephric fluid. If an abscess is present, this would appear as a well-defined hypoechoic area, typically close to the cortex or the corticomedullary portion of the kidney. Next, true or false? Multicystic dysplastic kidney is a potential cause of pediatric hydronephrosis. The answer is true. The obstructive type of multicystic dysplastic kidney can result in hydronephrosis. It is this type of multicystic dysplastic kidney in which you would typically see multiple renal pelvis predominant cysts, or a single large renal pelvic cyst that is causing obstruction. The pelvi-infundibular type of multicystic dysplastic kidney, on the other hand, is more common and has multiple non-communicating, typically small renal cysts, and is associated often with atresia of the ureter and renal pelvis. So the presence or absence of hydronephrosis can help distinguish between subtypes of multicystic dysplastic kidney. Next question. What are other potential causes of pediatric hydronephrosis? The most common cause of pediatric hydronephrosis is pelvi-ureteric junction obstruction. PUJ obstruction, pelvi-ureteric junction obstruction, accounts for about half of cases of pediatric hydronephrosis. Other causes of pediatric hydronephrosis include posterior urethral valves, vesicoureteral reflux, vesicoureteral junction obstruction, and megacystis megaureter. I want to note here the difference between pelvi-ureteric junction obstruction, which is actually a more common cause and the number one cause of pediatric hydronephrosis, in comparison to vesicoureteral junction, often abbreviated VUJ obstruction, which is a less common cause of pediatric hydronephrosis. And this brings us to the last and final question for this episode. What are the 4 grades of pediatric hydronephrosis? The 4 grades of pediatric hydronephrosis are as follows. Grade 1, mildly dilated renal pelvis and no dilation of the renal calyces. Grade 2, moderately dilated renal pelvis with mild calyceal dilatation. Grade 3, dilatation of both the renal pelvis and the calyces, and finally, grade 4, all of the above plus a thinned renal cortex. These 4 grades of pediatric hydronephrosis do tend to show up on things like radiology board exams, so I do think it is important. And with that, let's conclude this episode. I hope this information was helpful for many of you. Remember to download the free study guide on my website, theradiologyreview.com, if that is helpful for you. And remember, as always, keep up the good work and study hard. Remember, you have to study really hard to succeed on radiology board exams. So prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.
What's better than listening to the Radiology Review?
Nothing.
Well, true. But you could buy our book, The Board Exam Study Guide, Episodes 1 through 101. Available for purchase as a book on Amazon or in Kindle version.